Respiratory distress in the newborn. I'll be differentiating between all these diseases listed here on the left-sided column. Before we begin, there's a bit of an algorithm for when to suspect respiratory distress in the newborn. If you have a baby that has cyanosis and it's only the distal extremities that are blue and the SpO2 is normal, then you can just reassure. That's just peripheral cyanosis. That's relatively normal in infants, and it's not really a sign for alarm. If, on the other hand, you have mucosal or diffuse cyanosis, so if the baby's blue in the lips and kind of all over the face or on the chest, anywhere else, more than just the extremities, and there's a low SpO2, then that's central cyanosis. That's more of a sign for concern. You'll give oxygen in that case. If the SpO2 increases, then it's a pulmonary pathology and you want to give more respiratory support. You might want to intubate, you might want to ventilate. You can then kind of use this list to differentiate what's going on. If the SpO2 doesn't change, or if the patient is hemodynamically unstable, then you might suspect a cardiac pathology. In that case, you might want to give prostaglandins to keep the PDA open or see another algorithm for cardiac pathology. So we're going to be talking about what to do if that SpO2 increases and you suspect pulmonary pathology and you're giving respiratory support. What's going on with this kid? And some of these are more minor. Some of these might not even progress to that point with mucosal or diffuse cyanosis. So let's just work our way down. If you want to just study from this chart, that's great, or stick around and listen to me talk about it. So the first one is transient tachypnea of the newborn. The pathophysiology here is delayed reabsorption of alveolar fluid. This results in persistent fluid retained in the lung. The risk is thought to be related to C-sections, but it's unclear. The idea is that if you go through the birth canal, if you go through the vagina, you're kind of squeezing the fluid out of the baby's lungs, but it's not clear if that's held up in studies. The symptoms here are tachypnea. Usually it's more mild than the others on this list. They can have cyanosis, they can have hypoxia, but that's less likely. So really just, baby's grunting, baby's breathing heavy, breathing fast, mild tachypnea. Diagnosis, it's important to differentiate all these on chest x-ray, which is one of the first tests that you'll do. Babies with transient tachypnea of the newborn have parenchymal interstitial infiltrates. The chest x-ray just appears wet. It looks like there's fluid. You'll even sometimes see intralobular fluid accumulation, so kind of between the right upper and right middle lobe, you might see like a horizontal line of fluid. That's essentially the delayed reabsorption of the alveolar fluid. Treatment isn't too extensive. As I mentioned before, you'll just give them oxygen. You're going to support them. You can do CPAP and intubation if needed, but that's not always necessary. Most of these babies recover just fine. Next is respiratory distress syndrome. This is a combination of two problems. You have low surfactant, oftentimes from preterm babies, and underdeveloped lungs. Because of these two problems, you have increased alveolar surface tension. The alveoli cannot keep themselves open. Remember, because of the forces between water molecules, it's difficult to do that in the absence of surfactant. So the alveoli collapse and you have diffuse atelectasis, which we'll talk about on x-ray in a second. This diffuse atelectasis results in a ventilation perfusion mismatch and essentially creates a large intrapulmonary shunt. So the body is pumping blood through the lungs, but the lungs are collapsed, the alveoli are collapsed, and you're not, doing gas exchange. This, if severe, and if the baby's intubated for a while, can progress to bronchopulmonary dysplasia, which we'll get to in a second. But back to respiratory distress syndrome. The baby will often be preterm, as I mentioned. They'll have tachypnea, they can have retractions and increased work of breathing. They'll be hypoxic and cyanotic within minutes to hours of birth. The breath sounds will be symmetric, and they'll be coarse and decreased. Chest x-ray will show diffuse alveolar collapse. That'll look like air bronchograms, but more characteristically, they'll have that ground glass homogeneous infiltrate appearance. The lungs will also have decreased volumes. They used to use this L to S ratio, and that's greater than 2:1 for the L to S ratio. The treatment for respiratory distress syndrome is kind of supportive plus surfactants. You can give antenatal corticosteroids to try to prevent this, but this needs to be done at least a day before delivery. You can also add CPAP if that helps, but it's essentially caused by low surfactant. You can treat it with surfactant. Next, Meconium aspiration syndrome. Pathophysiology is the baby passing its first stool, meconium in utero. The meconium essentially gets breathed in by the baby, gets into the lungs. It's sticky and it's messy, and it causes a bronchiolar obstruction and irritation. Signs and symptoms here, this is usually a term or post-term baby. Being a post-term baby predisposes you to passing meconium in utero. Meconium has stained the amniotic fluid, so that might be a clue. They'll be tachypnic, they'll be hypoxic. The chest x-ray in this case shows lung hyperinflation, unlike the smaller lung volumes in respiratory distress syndrome. I kind of think of this as like a bronchiectasis type picture. You have this sticky meconium stuff that gets in and blocks air getting out of the lungs, so leading to lung hyperinflation. You'll see patchy bilateral infiltrates. It looks like pneumonia, and you can have atelectasis. You might even have a consolidation in there as well. Treatment for this is resuscitation, ventilation, oxygen, surfactant. So more supportive stuff, kind of the same treatment so far. So next, bronchopulmonary dysplasia. This is a result of prolonged oxygen therapy. So as in a kid who has respiratory distress syndrome who's been on oxygen for at least a month, it's often caused by respiratory distress syndrome. Yes, we said that, and extended ICU care. The signs and symptoms are recurrent DSATs, persistent O2 requirements. It's kind of similar in a picture to ARDS or NRDS, neonatal respiratory distress syndrome. They have tachypnea, grunting, nasal flaring. On X-ray, you'll see coarse lung markings with cystic changes. So it's kind of a progression from the RDS that it might have started with. It's gotten worse. You have cystic changes now. Treatment is mostly supportive. In this case, you might add diuretics if they have too much fluid accumulating. You can also add glucocorticoids to try to stop that inflammatory process going on in the lungs. Some babies improve. Some babies end up having pulmonary arterial hypertension for the rest of their lives, unfortunately. Next is congenital diaphragmatic hernia. The pathophysiology here is structural. It's a hole in the diaphragm that leads to bowel herniation. If the bowel goes up into the chest, then the baby has hypoplastic lung, so it impairs the lung development. Signs and symptoms here. This might be pretty obvious if you auscultate and hear bowel sounds over the lungs. You might have absent breath sounds on that side as well, depending on how small that hypoplastic lung is. Baby will also have a scaphoid abdomen because they don't have intestine in their abdomen. They have intestine up in their chest. And of course, dyspnea. Chest x-ray will be pretty obvious, loops of bowel in the thorax and a displaced cardiac silhouette. The heart has to go somewhere, so it's kind of pushed over to one side away from the herniating bowel. Treatment here is initial stabilization, intubation, ventilation. You can give them surfactant, you stabilize them, and then eventually you do surgery is the definitive treatment. Next is persistent pulmonary hypertension of the newborn. The pathophysiology here is fetal high pulmonary pressure. So remember, when baby's born, you have this big change in the circulatory system. When it's in utero, there's very, very high pressures in the lungs because the lungs are filled with fluid. As soon as baby's born, that should switch, and you should end up having a very low pulmonic pressure. If that pulmonic pressure remains high, they can end up with persistent pulmonary hypertension of the newborn, which leads to high right to left shunting across the PDA. So if you have high pressures in the lungs, the blood will be shunted through the PDA into the systemic circulation. Signs and symptoms here are respiratory distress, a prominent S2, which signifies the high pulmonary pressures. So remember, S2 is the sound of the pulmonic valve slamming shut, and if you have high pulmonary pressures, that's more pressure to make it slam shut even louder, so that'll be prominent. The diagnosis is largely clinical. You'll be able to do an O2 of the baby's extremities, and you'll notice that there's a lower post-ductal O2 compared to pre-ductal O2. So remember that the right arm's vasculature comes before the PDA, so that'll have a high or normal oxygen saturation, whereas the left arm or the lower extremities will have a lower oxygenation. So that makes sense. Treatment here is oxygen, ventilation, nitric oxide, which dilates the pulmonary vasculature, which essentially reduces the pressure of the pulmonary vasculature and hopefully fixes your problems. If you reduce the pressure of the pulmonary vasculature, more blood will go there, less will shunt across the PDA, and less will cause this hypoxia of the left arm and lower extremities. Next, apnea of prematurity. Almost done. We got 2 left. The pathophys of apnea of prematurity is immature respiratory centers in the pons and medulla. Essentially, it's the brain is not fully developed, and the baby doesn't know how to breathe on its own yet. This affects a lot of babies that are born premature, something like 99% born before 28 weeks. Baby will have intermittent apnea where it stops breathing for at least 20 seconds. They can also have bradycardia, DSATs. Otherwise, they'll be, a normal preterm baby. The diagnosis is clinical. You want to rule out other causes like infection and seizures. Infections can present pretty subtly in neonates, so that's something to look out for. Treatment here, unfortunately, is just to wait it out. You could use caffeine to stimulate baby to breathe a little bit. You could do non-invasive ventilation if the DSATs are pretty bad. Lastly, pneumothorax. This is the normal pathophysiology of pneumothorax. Air gets into the chest when it shouldn't be. It's often in the setting of mechanical ventilation. If baby doesn't have that much surfactant and you're constantly ventilating baby's lungs, you can pop a lung and cause a pneumothorax. The signs and symptoms that kind of differentiate from the others is that this is kind of an acute or sudden onset or sudden worsening of respiratory distress. You'll notice asymmetric breath sounds. The lung that is broken, the side of the pneumothorax will have decreased breath sounds. On chest x-ray, you'll see a radiolucent zone between the lung and the chest wall, just like in pneumothorax in adults. The treatment here is supportive. If it's a small pneumothorax, if it's a big pneumothorax, you might need needle decompression. So this was kind of a speed run of respiratory distress in the newborn. I hope it was helpful, and thank you for listening.